Welcome to a discussion of spinal cord anatomy, function, and dysfunction. The spinal cord, along with the brain, form the central nervous system. They are fed by inputs from cranial nerves and spinal nerves. The cranial nerves coming into the brainstem and the spinal nerves coming into the spinal cord. The peripheral nerves feed in through spinal nerves, so that the spinal cord is in a central location for getting information from the body and sending information to the body. The spinal cord, in fact, is the conduit between the brain and the peripheral nervous system, and is also an integrating center for spinal reflexes. All of the sensory information from throughout the body travels through the spinal cord on the way to the brain. Within the spinal cord, the upper motor neurons, which come down from the brain, travel through the spinal cord to end at various locations on lower motor neurons, and the lower motor neurons travel out to the muscles to activate the muscles and produce contraction. We'll first examine the segmental properties along the spinal cord at each level, both the sensory input, the motor output, as well as the spinal reflexes. And then we'll identify the different sensory and motor pathways within the spinal cord, known as the long tracts. And then finally, we'll address the vascular supply to the spinal cord and the impact of insults, either to the vascular supply or to the spinal cord itself. The spinal cord extends from the foramen magnum all the way down to the first and second lumbar vertebrae. There are 31 pairs of spinal nerves that emerge between pedicles of adjacent vertebrae. The spinal cord, as the brain, is covered by meninges, the dura mater, the arachnoid, and the pia mater. They protect the central nervous system from substances that are floating throughout the body. And there are also spaces between those layers and the spinal cord proper. Other features that we'll pay special attention to are the conus medullaris, cauda equina, and filum terminale. We see here the end of the spinal cord within the spinal canal, and we can see that it ends near L2, between L1 and L2, at which point we have the conus medullaris and the filum terminale, which anchors the lower portion of the spinal cord. And the cauda equina, which includes the nerve fibers coming off of the spinal cord or going into the spinal cord that extend down below the conus medullaris. If we look at the various levels of the body, we can see that it's broken up into various dermatomes, that is, regions of the body where sensation on the skin is conveyed into particular levels of the spinal cord, indicated here by cervical levels, thoracic levels, lumbar levels, and sacral levels. A dermatome is the area of skin supplied by one single spinal nerve. The significance of those dermatomes is that if there's damage to one spinal nerve at one level, it will affect sensation from that portion of the body that is a dermatome that feeds into that spinal level, so that it's C1, C2, it's the occiput, and so on, C3, C4, down to 5, the shoulder and lateral arm, and in particular C5 through C7 and 8, various portions of the arm and the hand. And then the thoracic trunk is fed largely by the chest and abdomen, and then the lumbar levels get information from the lower trunk as well as the leg, and sacral levels get information from the lowest portion of the leg as well as the lower portions of the body. Motor input is coming in a similar way, providing motor control from those lower motor neurons at these various levels of the spinal cord. And in particular, we'd like to recognize that certain reflexes, deep tendon reflexes, the biceps and the triceps, are controlled at particular levels of the spinal cord, in particular C5 to C6 for the biceps, C6 to C8 for the triceps, and similarly for the brachioradialis, C6 to C7. And complementary reflexes in the legs, the knee jerk is controlled by neurons coming out of L2 to L4, and the ankle jerk by neurons coming out of S1 to S2. Damage to a dorsal root would produce sensory deficit and decreased reflexes on the side of that damage. Similarly, damage to the ventral root would produce weakness and decreased reflexes at that level and on that side. So they're important guides for the effect of damage to the nervous system. If there's damage in the cord itself on both sides, it would affect then the dermatomes on both sides. Recognize the following terminology related to the spinal cord, and that is the dorsal roots are afferent pathways for fibers carrying sensory information from distal receptors throughout the body. And they generally terminate on dorsal horns, but possibly on ventral horns in the spinal cord to drive reflexes. They provide sensory information eventually to the cortex as well. Ventral roots are carrying efferent information from ventral horn motor neurons, and they will activate motor muscles in the periphery. They also contain preganglionic autonomic fibers at thoracic and sacral levels. The deep tendon reflexes are two neuron monosynaptic pathways in which a stretch reflex is activated when the muscle is stretched to activate a sensory fiber, automatically activate a motor fiber to the very same muscle to produce contraction of that muscle. Damage to either the afferent or the efferent pathway will result in decreased or absent reflexes. If the damage is to the afferent pathway, there'll be a loss of reflex, but also a loss of sensory information. If there's damage to the efferent component, the reflex, there'll be a loss of the reflex, but also weakness in that particular muscle group. The dorsal rami from various spinal levels separate and innervate synovial joints of the vertebral column, which are important in the muscles of the deep back and overlapping skin. The ventral rami are also distributed in the skin and muscles in a segmental pattern. And they often join with other peripheral neurons to provide information from the cervical and thoracic level, as well as from the lumbar level. The organization of a spinal nerve is shown here, where we see the dorsal root coming out, where we have sensory fibers coming in, and the ventral root, where we have motor fibers coming out. They join to form the spinal nerve. If there's damage to the spinal nerve, then we'd have sensory and motor effects that would be reflected at a dermatome and a myotome. Later on, those fibers will distribute and separate out to be sensory and motor fibers. And damage there would have a much more limited impact. We also see in this orientation that the dorsal columns in this dorsal position is also referred to as the posterior columns, or the posterior portion of the cord, whereas the ventral portion of the cord is also referred to as the anterior portion of the cord. And we can see that if there's damage to the root, we call that a radiculopathy. If there's damage to the more peripheral nerve, we'll call it a neuropathy. If there's damage to the spinal cord itself, we'll call it a myelopathy. When we see the spinal cord in cross-section, we see that a large amount of the outside is composed of white matter, and this white matter are made up overwhelmingly of axons. Whereas the central region is composed of gray matter, where we have cell bodies, and we have the central canal, portion of cerebral spinal fluid travels through the central canal. And we'll see that there are various tracts coming through the white matter, and we'll look at those subsequently. And we see that the incoming dorsal root comes into the dorsal gray, while the ventral root has motor neurons coming out of the ventral gray. We see that represented here, but in addition, we see that the pathway coming that includes corticospinal tract, that is the primary driver of lower motor neurons, is coming in this region in what's called the lateral funiculus. And at particular levels of the spinal cord, axons will come off the corticospinal tract to activate lower motor neurons and therefore drive contraction of that appropriate muscle. There are 5 main pathways in the spinal cord that we want to recognize. We'll start off with the ascending pathways, and the ascending pathways are the dorsal column. Dorsal column is responsible for conscious proprioception, that is to know where your limbs are in space, where your hand is, where your fingers are. 2-point discrimination, your fine discrimination. This conscious proprioception is sometimes called position sense. 2-point discrimination is your fine ability to touch things and know what they are by touch. And then vibratory sense is carried in this dorsal column as well. The dorsal columns are located on the dorsal portion of the spinal cord, and those for the legs are located in the gracilis fasciculus. Those for the arms are located in the cuneatus fasciculus. We also have information for pain and temperature coming in the spinothalamic pathway. So the spinothalamic pathway is recognized over here in a lateral position. It's the lateral spinothalamic tract, and it carries information about pain and temperature. There's a little bit of touch, crude touch information, but primarily pain and temperature, and that's what we'll be emphasizing. It's often referred to as the spinothalamic tract, sometimes the lateral spinothalamic tract to indicate its location. You'll also see the spinocerebellar pathway. Spinocerebellar pathway is located far laterally, and these are symmetrical on the 2 sides. Everything you see on one side is present on the other side. The spinocerebellar pathways carry information about proprioception, that is position of your limbs in space, but it's unconscious. It goes to the cerebellum, not to the cortex, not to the cerebral cortex. And then if we look at the descending motor pathways, we'll see 2 different groups. We'll see the corticospinal tract, the major driving tract for movement, and that's located in the lateral funiculus in this position, and the rubrospinal tract, which is located in an overlapping area next to the corticospinal tract. Those are responsible primarily for flexor movements and for distal portions of the extremities, fine movements, your ability to play the piano and to write with a pen and things like that. On the other hand, we see the reticulospinal tract and the vestibulospinal tracts. They're in the anterior funiculus, and the vestibulospinal tract and reticulospinal tract are most important for extensor muscles and for maintaining posture, so that they're somewhat less involved in the ongoing conscious movements that you initiate, but very important for maintaining posture and overall tone. This figure shows the relative role of the corticospinal tract on fine motor control and the vestibulospinal and reticulospinal tract on postural control. and that is the corticospinal tract sends its axons into lower motor neurons that are in the ventral portion of the spinal gray, but in this more dorsal portion of this little limb, where motor neurons to flexors are concentrated. And that is complemented by the lower motor neurons for extensors that tend to be concentrated in this more anterior portion of the gray matter. And these tend to drive extensor muscles and postural muscles. Also, in this more medial region of the gray matter, there's very strong input from the reticulospinal tract in particular, but also the vestibulospinal tract for axial muscles. Another structure shown here that we haven't discussed previously is the tract of Lissauer. Pain fibers that come in the dorsal root may synapse in the dorsal gray, but they often will travel first in Lissauer's tract for 1 or 2 segments to go up or down the spinal cord, after which they will synapse generally in the spinal gray on neurons that then cross the midline to the other side to occupy a position in the spinal thalamic tract, at which point they can travel up towards the brain. Now, we want to recognize that different muscle groups are represented in different locations of the central gray, so that the flexors, particularly those that are driven by the corticospinal tract, are in this lateral portion of the central gray, and they're getting input from the corticospinal tract, while the reticulospinal tract and the vestibulospinal tract more strongly activate axial musculature to control posture. These are much more involved in extensors than in flexors, both this region as well as the more medial region. Now we'd like to start to look at different regions of the spinal cord in cross-section and recognize the changes that take place as we move through the spinal cord, starting out in the cervical cord, which has the largest bulk of the spinal cord in a cross-section, because it has all of the information, sensory information that has come from the legs as well as the arms, and it has all of the motor information that's going to drive the arms as well as the legs. It also has a large information of pain and temperature coming from every level below this level of the spinal cord. So there's lots of white matter and large amount of gray matter, and this large amount of gray matter at the cervical cord because the arms have very strong neural control from the spinal cord at this level. So this portion of the ventral cord, the ventral gray, is very large and extended to control the finger and arm movement. As we go a little bit lower into the thoracic cord, we see that we have very little gray matter down here because there are no extremities at the thoracic cord, so you don't need so many lower motor neurons. There's also much less sensitivity of sensory input, and in fact your ability to distinguish small spots on the skin are much reduced on the thoracic cord compared to the fingers, for instance. So we have many fewer fibers, and this region has much less of the hand information coming through, but does have all of the leg sensory information. It does have all of the white matter that you need to control the legs still from over this region, and pain and temperature from lower regions. So this region hasn't changed very much, while the gray matter has diminished dramatically, and the cuneate fasciculus has diminished dramatically. We do see little bumps on the gray matter that represent location of cell bodies of the preganglionic sympathetic neurons. that are controlled by thoracic level. As we go to the lumbar cord, we see the gray matter expands because we're now getting more information, sensory information from the feet, and we're controlling the feet and the legs by motor neurons that are in this location. We have no cuneate fasciculus, but we have some gracilis fasciculus, but we're now starting to diminish that because that's now controlling the legs, getting input just from the legs. We also have much smaller corticospinal tract because the arm input has been lost, and the anterior spinal thalamic tract. The latospinal thalamic tract is also diminished. So the white matter and the gray matter is somewhat diminished, but the gray matter is significantly larger than it was at the thoracic level. We do see the fasciculus gracilis is present here. As we go lower to the sacral cord, we see even less white matter, and we've lost these big extensions of the gray matter because we have no limbs to control at this level, other than a little bit of input to the foot. And you see less gray matter for sensory input as well. But we do see some of the fibers that are traveling next to the cord that will form the cauda equina. And there is some minor elevation of this gray matter right here to represent the preganglionic parasympathetic neurons supplying bladder and pelvic viscera. We'd like to take a look at the vasculature of the spinal cord. The arterial supply comes from longitudinally oriented vessels, that is, vessels that are traveling the long length of the spinal cord. And there are two major groups of vessels. There's the anterior spinal artery that we see covers this in a single anterior spinal artery that sits right in this region between the two portions of the spinal cord, right at the midline. And it feeds all of the corticospinal input, the the spinal thalamic input, as well as the lower motor neurons at this level. So corticospinal tract, spinal thalamic tract, some spinal cerebellar tracts, but not the posterior columns. Whereas the posterior, there's only one anterior spinal artery. The posterior spinal artery, there are two of them. One that sits right here, one that sits right here, and each one of them feeds the dorsal column on that side. So that damage to one posterior spinal artery would affect sensation, dorsal column sensation, which is position and vibration and fine touch on that side. These vessels originate in the cranial cavity and they descend longitudinally all along the length of the spinal cord. Those arteries are seen here, the anterior spinal artery and the posterior spinal arteries. Recognize that they are fed, we've said they've fed from cerebral vessels, but those cerebral vessels are inadequate, particularly for the anterior spinal artery, to feed the lower portion of the spinal cord. There are segmental feeders coming in that are called radicular arteries that come in to feed these arteries as we get down to the lower portions of the cord. They become increasingly important because below the thoracic cord, the anterior spinal artery gets inadequate supply from the cerebral vessels. And it's highly dependent on radicular arteries that come in off of the aorta. The aorta, of course, is getting its input from the atrium. And off of the aorta, you have these intercostal arteries that then feed the radicular arteries, and the radicular arteries feed the anterior spinal artery. it turns out that there's a critical role of the great radicular artery down in the lower thoracic level, so that if it happens to be blocked, or there's blockage in the anterior spinal artery itself, it results in an anterior spinal artery syndrome. That anterior spinal artery syndrome is to interfere with function of all of the tissue that is supplied by the anterior spinal artery. And that includes the corticospinal tract and the spinal thalamic tract. That is motor control by the corticospinal tract and pain sensation by the spinal thalamic tract. And those would be lost at that level and at all the levels below that. Thus, we have reviewed the anatomy, the function, and the dysfunction of various parts of the spinal cord. If you have any questions, don't hesitate to contact me. Thank you.